This is going to be my talk on Understanding Vaccines 101, an introduction to COVID-19 vaccines. So as I said, I'm going to have to make some disclosures before I get started. The first disclosure is that I am an interstitial lung disease expert, but I am not an infectious diseases specialist. I am not an immunologist. I am not a virology basic scientist, and I am not an epidemiologist. Now, I will say I have learned about all of those things at various times in my training, some of them for 4-year degrees and others for a few months on a rotation during my training. And I have been very carefully following the literature. But I want to be clear that, my good friend Isaac Bogosh, many of you might be seeing him. He's on TV all day, every day. And this is what Isaac has basically closed his practice so that he can spend all day, every day, either educating, being part of committees, or reading about COVID-19. I, on the other hand, have continued to do my job. And I've only been reading about COVID during my free time. Now, that's many hours of free time. But I just want to be clear that I am not an absolute expert on vaccines, and so I will do my best. But my goal here is to give you an overview rather than a deep dive into a specific question or a specific mechanism of one drug. And I hope that this will really help to have you understand what we're talking about. I gave the talk to my wife in my living room yesterday, and she said it helped her, so hopefully you'll do the same. So in order to talk about COVID-19 vaccines, this is sort of how I thought we could break it down. We'll talk about 4 things. I think you first have to understand something called the central dogma of human biology, which is a term that we use to describe how the human body works. And I think you really have to understand that to know how typical vaccines work. That'll be the second topic. And then the third is how do COVID-19 vaccines work? And they are a little different, but you'll see that they're not as different as many people think. Then we'll talk about some special considerations, people on blood thinners, immunosuppressants, people with allergies, and those types of things. So the central dogma of biology. So what do we mean by this? So there is this concept of the central dogma of biology that came out around the time when we started to understand what DNA was. And so the concept here is that on the left, I have a picture of a cell. This is a human cell. In the center, you see the nucleus. The nucleus is the center of the cell that holds all the DNA. And I think of the DNA kind of like the blueprints to a house, right? It has all of the information that tells you about all the different rooms. Every component of every part of the body is in every nucleus of every cell in your body. And what happens in the cell is that your DNA is turned into something that's a little more portable. So you can imagine, the contractor can't take the full blueprint every single time they go to the construction site. So what they do is they make a photocopy specifically of the parts that they want. And this is called transcription. And that's when the DNA is transcribed into this special kind of intermediary thing called messenger RNA. And the reason it's said it's a messenger is it's the thing that's carrying the information outside of the nucleus. So these are basically photocopies of short segments of your DNA. That messenger RNA then leaves the nucleus. You can see it kind of going out and into the cell. And then it goes to a place called the ribosome. The ribosome is what we call the protein factory. This is where the proteins are made in your body. And what happens is the ribosome does, the medical term is that it translates the mRNA to make proteins. And the proteins are what makes all the parts of our body. So in this picture, you've got different kinds of proteins, chicken, beef, eggs, tofu. But in our body, the proteins to make your hair is different than the proteins to make muscle cells, different than the proteins to make bones. But each of those has its own messenger RNA that is the code, and the ribosome translates the code into the actual product. Once you translate that code, you'll end up with all these proteins, which in this picture is these blue squiggles that are all the proteins that were coded by that messenger RNA. So this is the central dogma of biology. This is how all humans function. What's different during a viral infection? So in this picture of a viral infection, what you see is that the virus itself, which looks like a moon lander here, will land on the cell and it will inject its DNA or RNA into the cell. So that's the process of infection, is the virus grabs onto the cell and it injects its own DNA or RNA into the cell. So then what happens? So now we've got our cell, we've got the virus having gotten onto the cell and injected its own genetic material. And once it's done that, its own messenger RNA travels to the factory, the ribosome, and basically hijacks the protein factory. And now, instead of making your own proteins, you start to make these virus proteins. And this is what makes you sick. You end up with virus proteins all over your body. Once the virus proteins start circulating in your body realizes that those are foreign invaders, and you start to make these antibodies that will attack it. And in my diagram, the antibodies are going to be the Ys. You'll see them in a second. But these Ys, or these antibodies, start to attack the viral proteins outside of the cell. And that does two things. The first is the antibodies fight off the current infection by dealing with those proteins. They basically just get eaten up by these antibodies. But at the same time, you can make those antibodies at any time in the future, so it can protect you from future infections, so that you don't even get time to get sick, because next time the antibodies are made really quickly. So now we've talked about the central dogma of biology. We've talked about what happens when you get infected. Next, we have to talk about how traditional vaccines work. So there are different kinds of traditional vaccines. And one of them is something called a live attenuated vaccine. A live attenuated vaccine is basically where, instead of giving the actual infection that you're trying to protect from, instead you infect people with a weakened version of that virus. The virus still infects you, but now this weakened virus doesn't make you sick. You make viral proteins, but it's much easier for your body to fight off. So you never get sick from this weakened version of the virus. Some examples are measles, mumps, rubella. These are all live attenuated vaccines. Chickenpox and smallpox, and the polio vaccines. All of these are live attenuated things where we figured out a way to weaken the virus, but we still infect you with it so that you can get that immunity. Another kind of vaccine is something called a conjugate vaccine. A conjugate vaccine is where you inject people with only a small piece of the virus protein. What happens now is that protein goes around the body and the immune system actually just makes antibodies directly against those proteins. So this actually bypasses the entire infection process. You just inject protein and your body makes antibodies. So examples of conjugate vaccines is, the best example is our annual flu shot. So this is how the flu shot is made every year. You don't actually get infected with the flu. People who say that they got the flu from the shot, they may have gotten a flu at the time they got the shot, but biologically it is not possible that they actually got a flu infection because they never got a flu injection. They just got a few little proteins of the flu in their arm. So next, how do COVID-19 vaccines work? So this is actually kind of neat, and if you're interested, I think this is super cool. What they do with COVID-19 vaccines is, remember, I've got the picture of the cell on the left and a picture of an example of when a virus infects the cell on the right. So what we do now is we inject a short segment of this naked COVID-19 RNA directly into the body. So to give you an idea of what that looks like, and this is particularly the Pfizer and Moderna vaccine. To give you an idea of what that looks like, imagine, look at that picture in the center of the virus attacking the cell. And basically what we do is we have grabbed just a little bit of that viral mRNA and we inject that into your body. This tricks the body into making these little bits of viral protein. But you never actually get infected with the full virus. All you have is that little bit of mRNA that encodes one part of the virus. And everyone's sort of now familiar. We keep talking about this spike protein. That's the protein that we've decided, the spikes on the outside of the virus, or what we've decided to copy. These bits of viral protein, they can't survive on their own, but they're enough to encourage your body to make those antibodies, like we talked about at the beginning, so you're protected against future infections. And this is how the Pfizer and Moderna vaccines work. The AstraZeneca and Johnson & Johnson vaccines are slightly different. What they've done is they inject patients with an adenovirus. This is an actual virus that is able to infect humans, but doesn't make them sick. And what they've done with that adenovirus is they've modified it by taking a short piece of that viral mRNA and they put it inside the adenovirus. So now there is an actual infection because that adenovirus will infect the cell, and in the same way, it tricks the body into making these non-functional bits of viral protein. And similar to with the naked mRNA, the AstraZeneca and Johnson & Johnson one, where they use this adenovirus, it's not enough to make people sick, but it's enough to encourage the body to make antibodies to protect against future infections. So you can see that they're actually very similar. It's just a matter of whether or not you inject this quote unquote naked RNA, or if you encase the RNA in a virus particle. So why would you do that? Why would you encase the virus in a virus? Why would you encase the mRNA in a virus particle? Well, the answer is that RNA is very unstable. It breaks up within hours of being at room temperature. It can't survive outside of living things. But viruses survive really nicely. And so this is why you keep hearing about how the Pfizer and Moderna need to be kept at like minus 400 degrees Celsius. It's like, you know, deeper than the deepest North Pole. Whereas the AstraZeneca and Johnson & Johnson can just be kept in a fridge and might be able to be given at regular pharmacies. So this is a big advantage, because by putting the mRNA inside another kind of virus, you can keep it stable for longer at room temperatures or at regular temperatures. So now we understand the central dogma of biology. We understand how we get infected, how regular vaccines work, and how COVID-19 vaccines work. So there are some common questions that I've been asked many dozens of times, many days of the week that I thought I'd try and answer for you to begin with. So the first question is, should I be nervous about these new kinds of vaccines? And so the answer is that this isn't actually new. This technology of mRNA vaccines has been worked on for decades. In fact, all of the research into vaccines for HIV have been experimenting with mRNAs. And that was the idea of how we would make an HIV vaccine. The problem is it doesn't work in HIV, but the technology has been in research and development for about 20 years. And so we know from tens of thousands of people before we even started using COVID-19 vaccines, the technology is safe. We had given mRNA vaccines to tens of thousands of people, and we're really not seeing any major reported side effects other than those that we see with regular vaccines. So in a way, this idea, like a lot of people are unsettled by how quickly we've made the COVID-19 vaccine. But in a way, it's really just a product of lucky timing. Similar to how we're lucky that we can do Zoom chats, right? If SARS had exploded like this, who knows what the world would look like? Because we couldn't have done Zoom chats or video conferencing back then. Everyone would have just had to stay home and not interact with anybody. The same way, COVID-19 vaccines are just coming at the right time when we have this technology already available. Pfizer and Moderna actually had multiple HIV studies ongoing. And when COVID came, they just stopped, changed tack, made slight alterations to the mRNA, and started making it as a COVID vaccine instead of an HIV vaccine. Is one vaccine more effective than the other? So the news media keeps referring to different levels of effectiveness of the different vaccines. And we can go into it if we want, but to be honest, I think it's a bit outside of scope. But the take-home message here is that there are lots of differences in the study design and the timing of the studies that would explain why these top-line results that you're seeing in the Globe and Mail will be different. and may not be a true reflection of the vaccine effectiveness. So whereas Pfizer and Moderna describe that they're 94% effective and AstraZeneca is in the 80s, there's actually a lot of reasons in the study design to suggest that that may not really be a true difference. It's just a difference in how the studies were designed. What is abundantly clear and keeps coming up over and over again in every single piece of data that gets published is that all 4 vaccines currently approved in Canada, available is probably not the right word, currently approved in Canada, because Johnson & Johnson is not yet available here. But all 4 of the vaccines are very, very effective at preventing severe infection, hospitalization, and death. And the reality is that's all we care about. Like, no one cares if you turn COVID-19 into something that gives you a little bit of the sniffles. What you care about is, are you going to die? And all 4 vaccines are very effective at that. And I will say that I would be happy to have any member of my family get any vaccine that they could get their hands on. And I have said this. In fact, I believe my father-in-law is on a list to get the AstraZeneca vaccine, and I know there's going to be a million questions about it. But he asked me, and I said, go ahead, get on that list. So then the question is the AstraZeneca vaccine safe? So I've been very clear that I think that the AstraZeneca vaccine is effective. There is no one doubting. At the very beginning, there was some doubt about whether or not it worked in people over 65. But to be honest, very few people really believe that doubt, because in the UK, we were already seeing that rates of COVID-19 infection where they're only using AstraZeneca were going way down in the over 65. So we never really doubted that it worked in over 65. But the safety is the one that keeps coming up over the last few weeks. And so it is possible that the AstraZeneca vaccine may be associated with a risk of blood clots, particularly in younger people. I want to be really clear, the rate of blood clots has been extremely low. In fact, the rate of blood clots with AstraZeneca vaccines is so low that it seems to be lower than what we traditionally think of the rate of blood clots in the general population. And I suspect that this vaccine will turn out to be safe and effective, but I understand why many of my patients are nervous to get that vaccine. Health Canada is continuing to investigate this. The data is changing day by day. In my mind, I think all of the vaccines are fine. But every day I get patients who say, I don't want the AstraZeneca vaccine. And I say, fine, I don't care what you want. Just get vaccinated. Get whatever it is that we can get into your arm. And if you don't want to get AstraZeneca, fine. Wait a few extra days and get a Pfizer. But get something. Another question that everyone's asking me is one dose enough to protect me? It's funny, my mother actually, like, this is true, I cannot tell a lie. My mother actually emailed this to me at like 1:10. I only got 1 shot, and now I'm worried that it's not going to work. As many of you know, in Ontario, we're delaying the 2nd dose up to 4 months. This timing has never been tested. This was not in any of the trials. We have no real idea in a clinical trial if this works. What we do know is that in the UK, they are only giving 1 shot of AstraZeneca. It is the only vaccine that they have. They have all of their COVID is one of these variants of concern, the UK variant. And if anyone wants to type in COVID-19 rates UK, you can see that whereas our rates have gone down and are starting to come back up, in the UK, where a big percentage of their population has been vaccinated, their numbers are going down, 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 down. That's after only 1 shot of AstraZeneca. So although we believe that the 1 dose of vaccine provides some protection, it may not be as good as the protection from 2 doses. And so we have to remember that it works, but it may not be as good. So patients still need to be practicing all the appropriate safety measures, masking and distancing, until about 1 month after their 2nd dose of vaccine, no matter which vaccine it is. So I think it provides real protection, but it's probably not as good as 2 doses. Now, can we get the government to give you a 2nd dose? I hope so. There is active and ongoing advocacy to get a 2nd dose within the time frame that's been recommended for high-risk populations, particularly people with chronic lung diseases and things like people on this call. But at the moment, the government has been more focused on getting as many people vaccinated as possible, and they're just not listening to us. But there is ongoing advocacy to try and say there might be a specific group of people who really needs a second shot, and stay tuned. You know, this is literally changing every day. In the last bit, I'm just going to talk about any special circumstances that you should be aware of. And when we talk about special circumstances, I want to be really clear. All Canadians should get a COVID-19 vaccine as soon as possible, but there are a few special circumstances. So the first one is I'm taking a blood thinner. So patients who are taking strong blood thinners have to talk to their doctor before they get their injection, because there is a risk that they can bleed in the muscle after they get the injection. So your blood thinners usually need to be stopped for a few days before your shot. Examples of this are in the list below: Coumadin, Eliquis, Xarelto, and Shapera. All of these blood thinners will need to be held before your vaccines, and you should talk to your doctor about how long to hold them, because each drug needs to be held for a slightly different amount of time. I'm taking medications for my lung disease. How does that affect my COVID-19 shot? So I cannot say this more clearly. Antifibrotic drugs, some of you will be familiar. If you're on these drugs, you'll know them. Esbriet or pirfenidone, and the other drug is Ofever and Nintedanib. It is very clear that these drugs have no impact on vaccine safety or effectiveness. And I can tell you, I understand how vaccines work. I understand how these drugs work. And it makes absolutely no sense that either of them would have any impact on how the vaccine works. It's sort of like if my dad said, my left foot hurts, but I also want to get a new pool. Those two things are not related. And there's no way that they are related unless he can't swim because he's going to drown because his leg doesn't work. Right? They're not related. So I get asked it over and over again, but I can say that it doesn't even make sense that Esbriet or Ofev would impact how the vaccine works. But there are drugs that really do impact how the vaccine works. These anti-inflammatory drugs like mycophenolate or prednisone, many of our patients, particularly patients with hypersensitivity pneumonitis or scleroderma or other rheumatism diseases, are on these anti-inflammatory drugs that push down the immune system. Now that you've seen how these vaccines work, you can appreciate why there is no danger in combining these drugs with the vaccine, because we're not injecting you with anything that can make you really sick. The problem is, if we're pushing down your immune system, you may not develop as good an immune response. So these drugs might slightly reduce the effectiveness of the COVID-19 vaccine. But in most of our patients, we feel that you should just continue these drugs, take your vaccine, and the hope is that by the time you've gotten your second dose, that will be enough to really give you a good immune response. But particularly, these are the patients where a single dose may not be as effective as 2 doses. And there is one special exception, and I don't usually like to make a whole point of one exception to the rule, but this exception is so important, it's worth taking some time. If you're on a drug called Rituxan or rituximab, you would know if you were on this. This is an IV drug given 4 times a year. You couldn't be given it without knowing. But this drug, the way it works is it stops the body from making antibodies. That's what we use it for. And so it is thought that this drug almost certainly has a major impact on the COVID-19 vaccine effectiveness. There's no danger there from the vaccine, but it probably doesn't work if you take rituximab and then get the COVID-19 shot a week later. So you have to talk with your doctor about when the right time is to get the shot so that we can try and time it so that the rituximab is getting out of the system just as the vaccine is getting into the system. And that takes some timing. So to finish off, where and when can I get my COVID-19 vaccine? So patients with all kinds of ILD are eligible for vaccine in what's called phase 2. But phase 2 is not a really good description. They should probably call it phase 2A, B, and C. because the phase 2 people have been broken down into very high risk, and at risk. So right now, we're in phase 2A, the very high risk people. Those are people who are extremely high risk, and that is not our patients. The people who are considered high risk by the government are people who have lung disease and are on these immunosuppressive drugs, medicines that make your immune system lower. Prednisone, Cellcept, Myfortic, azathioprine, rituximab. These are the drugs we use that push down the immune system. These are not the drugs like Esbriet and Ofev. Those people who are on the immune suppressing drugs are at high risk, and they can be vaccinated either now at some places or very soon in other parts of the province. But the people who just have regular lung disease, like IPF or other kinds of fibrosis where they're not on immune suppressing drugs, they're in phase 2C. They're considered at risk, and they cannot get their vaccines yet in the Toronto area. Some places will let you pre-register, but you can't get an appointment yet. You do not require a physician's note to register for a vaccine. We're using this honor system to give access to the high-risk patients and the at-risk patients. So I want to be really clear, I am not saying this so that you'll all go and lie, but I am saying it instead so that you can not feel like you need to call our office and ask for notes to prove that you have a lung disease to get you into phase 2A, B, or C. You now understand where you qualify. When you sign up, they will ask you to say how you qualify, but you do not need a letter from your doctor. There are 2 ways that you can sign up for your vaccine. One is through the Ministry of Health website. The link is right here. It's really easy. Just type in Ontario COVID-19 website and it'll come up. On the Ontario website, you cannot book if you are anything other than phase 2A, and very few people on this call will be phase 2A. We're phase 2B and phase 2C, depending on what drugs you're on, and we cannot register on the provincial website right now. But the UHN has their own website, and you can go to it. You can search it. Here's the link here, or you could just go online and type in UHN COVID-19 vaccine. Our patients are allowing the phase 2B, the high-risk people on immunosuppressant drugs. They can register right now. The phase 2C people who are not on immune-suppressing drugs will probably be able to sign up within the next couple of weeks. We're not talking about months, we're talking about weeks. So to summarize, the central dogma of biology was that DNA in the nucleus is transcribed into mRNA. mRNA goes to that ribosome factory and gets translated into proteins. That's how all of our cells work. And in order to understand how vaccines work, you have to have a basic understanding of what's happening in your cells. Live attenuated vaccines are when we inject these weakened versions of the virus to make antibodies. Conjugate vaccines, like the flu shot, are when we just inject pieces of the viral proteins. We never get infected. We just make antibodies directly at those proteins. And the COVID-19 vaccine is somewhere in the middle, where we inject mRNA either alone or within a different virus that doesn't make people sick into the body to kind of trick the body to make these little bits of COVID-19 proteins to help make protective antibodies. And the real take-home message is everyone with ILD should get a COVID-19 vaccine as part of the phase 2 rollout. But there are some subtle things that you needed to know about with respect to blood thinners, immunosuppressants, that I wanted to make sure we talked about today. As many of you know, although I am often the face of our clinic, I am thrilled to have an enormous and fantastic team. This is a list of some of the doctors, administrative assistants, research staff, nurse practitioners, and fellows who allow us to take care of patients, and I couldn't do any of it without them. So I'm going to stop my presentation there. Then I'm going to open up to some questions. Mandy, I know you had some questions.
Yeah, so I think I can thank Shane for that presentation. That was great. I learned well with pictures, so I appreciate all your pictures. I think you answered most of the questions that I was emailed. But quickly, there's one that says, it's about mixing and matching vaccines. So say you had the first dose of the Pfizer, should you get a second dose with Moderna, or in the future, will you be able to get another dose of a different vaccine for COVID-19 specifically?
That's a great question, and really interesting. And now that you kind of understand a little bit about what's going on, you may kind of understand why I'm going to give the answer I'm going to give. So the different, even though in my picture, both of the different types of vaccines use that same little curlicue of the spike protein, in reality, they are slightly different between the vaccines. So they're all part of the spike protein, but they're different parts of the spike protein within the AstraZeneca, Johnson & Johnson, Pfizer, and Moderna. And so if you make antibodies against one part of the spike protein, that doesn't necessarily translate into another vaccine. The other company's vaccine for your body, it's like a whole new thing. And so if you get one vaccine, you could not necessarily get a booster with another vaccine, because it'd be like, your body recognizes roses and then you inject daffodils. They're similar, they're both flowers, but they're not exactly the same. So it wouldn't be considered a booster. On the other hand, you certainly could get roses and daffodils. You could now get a Pfizer vaccine, and then 6 months from now, if it turns out that the Johnson & Johnson is really the be all and end all, and that's what wins the day, then a year from now, I would not be surprised if we ended up changing and getting other vaccines. And this is the same the other way. If you are not happy with your choice that you got Johnson & Johnson because there was no Pfizer available, and then a year from now, when everyone's been kind of vaccinated, they're going around for second rounds, maybe that's when you get the Pfizer one. I do think that because of these variants, right now, by the way, all of the vaccines are pretty good against most of the variants, particularly the variants that are in Canada, right? The UK variant is what we're seeing in Canada, and all of the vaccines work against the UK variant. But it would not surprise me at all if down the line we end up having to get boosters, kind of like how you get a flu shot every year, because there's some change in the flu every year. And so I suspect that eventually we'll all be getting, we'll get a Pfizer now, and then next fall we'll get a shot for an AstraZeneca because they'll have the better one for the new variant. And then a year later, we'll get a shot for Moderna because they'll have the best one against the variant that's going to be bothering us in 2025. I suspect that this is not going to be one pair of vaccines and then you're done. But we'll probably have to get 2 shots of each company's vaccine once you make the transition.
Perfect. The questions I was emailed, you answered all of them actually in the presentation. So if anybody has any other questions, or Shane, are you okay for time? Or if you want to send them in the chat, I could read it out loud. Whatever.
Yeah, I can go into the chat. There's a few questions in the chat, and I'm okay to keep answering questions as long as they are, unless I've done such a fantastic job that there's no questions left. That's usually how I take it when I give talks and there's no questions. Or it was so bad that nobody really even understood what I was saying. So there is a question that asked me, will you get notified when the registration opens up for phase 2B or phase 2C if you registered? And so this is interesting. It's a great question. And so the official answer is yes, you will be notified. If you've pre-registered and you qualify, you will be notified. That's the official answer. The unofficial answer is that just last weekend, when it was actually really nice weather, I had a friend over who works at a downtown hospital who's in charge of the vaccine rollouts at that hospital. And she sat in my driveway, and we were very distant apart from each other, yelling down my driveway about our experiences. And she is one of the keepers of one of these pre-registration lists. And the problem is that at that hospital, they had something like 25,000 people pre-register. And they have no real idea how they're realistically going to know. A lot of them pre-registered without being able, before we really knew about this phase 2 A, B, and C. And so she says, like, we have no real way. We're going to we're going to send out blast emails that say, hey, you may be able to register now for your shot. But she said, we're kind of lost. So I think I've been saying the same thing to all my patients. The squeaky wheel gets the grease. So if you're registered, that's fine. But there is very little harm in registering everywhere, in going back every week and seeing if you can sign up now, and keep on bugging. I was amazed that one of my family members was one of those people who just kept on bothering. And then she got, I don't know if you heard on the news, but they were like going to have some vaccines that were going to go bad somewhere because they couldn't find over 70-year-olds to do them. And so she just happened to check that day, saw that they were giving them out. She didn't meet phase 1, 2, or 3, but they were shots. And she said, okay, well, I don't want it to go to waste. And she signed up that day and got her shot. We had a discussion about the ethics of that, because in a way she jumped the queue, but on the other way she said, but that thing was going to go in the trash otherwise. And I said, you're right. If they were letting you sign up, you go ahead, you take what you can get. So the squeaky wheel gets the grease. The only thing I will say, if you register at multiple places, once you do get an appointment and you get your shot, please have the courtesy to go back and cancel and keep track of where you're registered and cancel everywhere else. Because the worst thing that can happen is that you have 6 appointments and those are 5 other people who won't get an appointment because you're taking up 6 slots. Someone's asked me the question of whether or not I would recommend getting the AstraZeneca if I've had a TIA or a stroke in the past. You know, I think all the riders that I said about the AstraZeneca vaccine, the problem is that you may not trust my answer, because I've already told you I would be willing to have almost anybody get the AstraZeneca vaccine, because I don't know if I really believe that there's a problem here. Having said that, it is a really good question. And the answer that I would give you is that the kind of blood clots that they're seeing with the AstraZeneca vaccine is what we call a venous blood clot. So this is happening in the veins of your body. Those are very different than TIAs and strokes, which are blood clots in the arteries of your body. And in most of medicine, we believe that clots in the artery system and the venous system are actually very different things, and they have different risk factors. And I am not aware of any reports of TIA or stroke from the AstraZeneca vaccine. So with all the caveats of no one knows for sure, and you know I'm a booster for vaccines, so maybe you don't believe me, but I will say that I do not believe that a TIA should be a reason for you not to get a shot, any shot, particularly the AstraZeneca. The other question that's very closely related to that is this idea of allergies and people who have allergies with the Pfizer vaccine. We haven't been talking about that so much anymore. But early on, there were a few people who had allergic reactions, and there was a question of whether or not, if I have allergies, can I get the Pfizer vaccine? And I think similarly, those are, allergies like, certain foods make me sick, or penicillin antibiotics give me rash, is very different than what you're getting injected with the Pfizer vaccine. So in general, I do not believe that allergies should be a problem unless there is a specific reason to think that you would have previously had a life-threatening allergic reaction to something that we would think would be in a Pfizer vaccine. That was a big concern a few months ago, but now that 100 million people have gotten Pfizer and there's no real discussion about allergies, that's sort of falling off the radar. There's a great question here that I think is a really good one. So this one, it gives me chills to think about it, because I know we're all asking the same question. So can I hug my daughter after I get my COVID-19 shot? Right? And when can I hug my daughter? I wish I had the answer to that question, because I have not hugged my parents in over a year. My kids have not, and everybody, we're all getting teary, right? It's been a tough year. In the United States, the NIH has come out and said that people who have received 2 shots of vaccine and are completely protected, meaning that about 2 to 4 weeks has passed after their second shot. In the US, they are saying that people who are vaccinated can be with people who are vaccinated without wearing a mask, indoors, basically living normal life. So fully vaccinated people should be able to live with fully vaccinated people without any worries. They're even starting to say that fully vaccinated people can be with one unvaccinated person, with the idea being that if, my wife and I are vaccinated and we're hanging out with my mother-in-law, if we're completely vaccinated, she can't really give us the virus. And more data from the UK and Israel is suggesting that we can't really give her the virus. And so it's probably safe for us to hang out with our mother-in-law, although she won't hang out with us, even though we're both vaccinated. But what is not nearly as clear is what happens after a single shot. And so I do believe that a single shot definitely provides some protection. I actually think it's a lot of protection. But I think that at the moment, I think that we all probably still need to just hold on a little bit longer and keep being safe and protecting ourselves by not hugging those people. But just know that the sooner you get your first shot, the government is telling you it's only a maximum of 4 months. Like, you've done this for over a year. Get your first shot, stay safe. 4 months later or earlier, you're going to get your second shot. And then 2 weeks later, go to town.
Great. I think maybe you were being sent some direct messages.
I was getting sent some direct messages. Did you get any, Mandy?
I mean, I did see the last two that you asked. Those were sent. But does anybody have any other questions or?
No? Great, thank you.
Yes, Bob here. Bob here, I've got a question. With IPF, we're classified as 2C, you said earlier, Doctor. And you were talking about pre-registration. Are you suggesting that it would be advisable then that after I've already had my first vaccine, first jab, are you suggesting that then that I should be registered with UHN for the second one, rather than, so I can perhaps be a little bit quicker than the 4 months that I would get through your region, which is the area I live in?
That is a fantastic question, a really good question. And I actually hadn't even thought about that. And the answer is no, I would not recommend that you do that. There are a couple of reasons why you don't want to do that. The first reason is that if people start getting one shot at one place and another shot at another place, it's going to be really hard to keep track of things. And in particular, what it's going to be hard to do is to make sure that you're getting the same vaccine from the same company, and to make sure that appointments are not lost or missed or double scheduled. So I think when you get your first shot, you should be committed to getting your second shot at that same location at the timeline that they are inviting you back. So once you get your first shot, you will be in the system, and you are going to get specifically called for your second shot. You're going to be told about that appointment, because once you've had your first shot, that's different than pre-registering. Now you're actually in the system, and they have a mandate to reach out to you to give you your second shot. So I would say, and my worry is that they may be holding that second shot for you, and it might not go in another arm if you got your second shot at another location. So I think you should, once you've had your first shot, go back to that same location for your second shot. Do not try and jump the queue, because that, even though we want to get our second shot early, that is against the rules. So you're stuck getting your second shot where you got your first one. But just know that the clock is ticking, in that it can only be, the government has said it's only going to be 4 months or less before you're going to get your second. So once the first one's done, you're on the path to getting that second, and get it at the same location. It'll be a scheduling nightmare if people start going to different places.
Yeah, okay, doctor, thank you very much. In fact, when they gave me my first vaccine, they did give the exact day and time for the return date for my second one.
That's it. And if you get the shot somewhere else, even if you kind of call them and tell them, the left hand won't know what the right hand's doing. And that second shot is going to be sitting there waiting for you at some point, and it might go bad because they'll just assume that you're coming for it. So I think it's better to take that appointment. There was a question about what about your caregivers? What about the people who are caring for people with IPF? Can they qualify? And I think that they can pre-register, but at the moment, they are not being offered vaccine unless they're caring for someone who's in a nursing home. They are specifically watching the nursing home people, which is a super interesting thing to watch if anyone's been looking at the nursing home data. If you ever wanted to know if COVID-19 vaccines work, just look at what's happening in the Ontario nursing home. It was a travesty what happened exactly a year ago. But now, while COVID-19 is spiking rapidly out in the community, there's talk that a nursing home is probably about the safest place to be in March of 2021, because there's basically no outbreaks in people who've been vaccinated in the nursing homes who've gotten both shots. And if there are outbreaks, it's usually with healthcare workers who haven't gotten their vaccine, not the people living in the nursing homes. So I think if at the moment you're not a candidate, but I do believe that those people, and Mandy, I don't know if you know and you can correct, but I do believe that caregivers qualify in phase 2C, which is sort of the same category as like frontline workers who are like, you know, the grocery store clerks and things like that, people who are forced to be in direct contact with others.
Yeah, I think I've heard of some, that is true in phase 2C, but I have heard some, if you're associated sometimes with the LIN, and you have a caregiver in your home with the LIN, and you may get access to the vaccine, but they'll contact you.
Yeah, that's a great point. People who are getting access to home care, CCAC, or any care through the LIN, they actually qualify in phase 2B, I believe it is. And so you and any family members who might be in the house, this is interesting. It's not actually to protect you, it's to protect the nurses who are coming into the house. So they want to make sure they're going into houses where everyone is vaccinated so you can get it. Now, I will say I have heard stories of family members showing up with their loved one to get the shot, and they've gotten poked. So I don't recommend, if you get a vaccine appointment, I do not recommend that you go with like your children, grandchildren, and great-grandchildren to show up to the vaccine. But if there is one person, for example, who is closely involved with you, a sibling or a child who has been one of your care providers, and let's say you were able to get the appointment and they're the ones who drive you to that appointment, I have heard stories that if you just happen to get lucky and you show up and they've got extra shots that day, they have given those to people, although there's no guarantee that they will get it. But there's probably little harm in bringing one person with you when you get your shot to see if you can squeak them in under the radar. All right. I think I know when I've worn out my welcome, and I can feel it. No, I'm just kidding. I can see lots of nods. I can see you're all still there and engaged and awake. I hope this was informative. As I say, I'm not a virologist, I'm not an epidemiologist, but I really do understand how these things work. And to me, understanding is the key. So we didn't do deep dives into specific rates of blood clots. We didn't do deep dives into exact percentages of X, Y, and Z. The messaging today was to try and give you a general overview of what vaccines are, how they work, why we think that they're safe, even though we've invented them, we've quote unquote invented them so quickly, and some of the special circumstances that our patients need to be aware of. If you haven't already gone to pre-register, I encourage you, get off the phone. If you qualify in phase 2B, register at the UHN. If you're a phase 2C, just watch the news every day, wait for it. It is not going to be far away. Like, we're talking days before you're going to be able to register. So I hope that the next time I get invited to talk to you guys, it's back in person again, and we're all vaccinated, and maybe we can do that hug that we are so promised, right? Well, I'm not going to hug you guys, but I might hug my family. I mean, I have to help. Bye, everybody.
Okay, perfect. Thank you.
Thank you.
Thank you,
Thank you
Doctor.
so much.
You should tell Dr. Gomez to move over.
I'm not looking for another job, but thanks for the offer. All the best, everybody.